Next, we'll bring up someone who I don't think needs any introduction. Frank Criado is going to talk about the ticking time bomb debunked, rethinking when to treat and how to size AAAs.
Thanks very much. I don't have any conflicts to share. I think in the medical profession in general, and really people generally, view aneurysms, particularly aortic aneurysms, of course, as something that is where rupture and death are essentially inevitable and unpredictable. Well, neither is true, really, generally speaking. Such grim outlook and fears were fueled by these kinds of figures of annual risk of rupture that were disseminated more than 20 years ago. We now know that the reality is quite a bit different. And this has come from a closer scrutiny of contemporary series of patients, importantly from systematic reviews of medically unfit patients with large unrepaired AAAs, revealing a lower than expected rupture rate and mortality, beginning, of course, with the EVAR2 UK trial. And an apparent, as we are all aware, ongoing decrease in AAA rupture rates and also AAA prevalence. So these are the figures that have emerged over the last few years, indicating a more realistic contemporary annual risk of AAA rupture. As you can see there, the numbers are considerably lower than those old figures that infuse so much fear in the minds of all of us and everyone else. Still significant, and of course these numbers are cumulative, meaning 3.5% annual risk times 5 years or times 10 years is something that adds up to something very significant, of course. But unnecessary and excessive fear, creating so much unhappiness on our patients, and to rush decision making really leads to no good, and is unnecessary. That is not to say that an aneurysm like this is not something that immediately threatens life and should be repaired, if possible, urgently, of course. At the time of measuring and sizing, some of you, I'm sure, must have seen Janet Powell's presentation at the VIF symposium last November, and the year before, actually, as well, but she enlarged on that this past November, beginning with ultrasound, of course, a longitudinal view in order to pick the best AP diameter, because that's what we are supposed to measure, the AP diameter. So once you made that decision, you have choices to be made. Inner to inner, for instance, in this case, 3.6 centimeters, obviously a patient to be followed. Maybe every 2 years, at least in the UK, perhaps similar in this country. Or you can go outer to outer. And in this particular case, it was slightly above 4 centimeters. So another review and follow-up in 1 year. Or you can do other things, particularly something like this. Same patient, same AAA, now 5.3 centimeters. Perhaps we should fix it. Imagine that. Now, for those of you who may be thinking, well, we don't really use ultrasound anymore except for follow-up or whatever, we depend on CT, I remind you that just very recently, the SVS 2024 clinical practice guidelines reaffirmed this concept that in line with recent data, it is clarified that the diameter threshold for considering repair should preferably be based on ultrasound, reserving CT for procedure planning. The current 5.5 cm diameter to recommend elective repair in men was arrived at in studies, of course, that use inner to inner ultrasound measurements. I remind you that the inclusion of the aortic wall adds 4 to 5 millimeters minimum. Thus, a 6 centimeter aneurysm on CT, which is always measured outer to outer, is generally equivalent to that 5.5 cm threshold, a fact that escapes most vascular surgeons to this day, I think. And one other thing that is interesting. When they were trying to decide in the early 1990s just what threshold to use, there was a great deal of discussion, mainly in the UK, about whether to use 6 or 5, perhaps other numbers. And finally, they settled on 5.5, but it is, this number, a largely arbitrary number. Just remember that. We've heard forever, of course, about the law of Laplace and how that applies so well to aneurysms and the risk of rupture. What it really doesn't, maybe in general as to the principles, but this law is based on cylindrical geometries, whereas AAAs, of course, are complex structures. So it therefore fails to predict realistic wall stresses. So what is wrong with using diameter alone? And that's one of the messages I would like you to leave here with. But variability, inconsistencies, CT versus ultrasound measurements, as we discussed. Small aneurysms, as we know, can rupture, and large ones can remain stable. Diameter alone fails to take into account geometry, of course, and aortic wall stress strength. So all of those are clear downsides. So non-diameter rupture risk parameters have emerged over the last 15 to 20 years, and particularly the last 10 years, as they are listed on that slide that is in front of you, particularly finite element analysis and a few other things that increasingly are becoming more important, and I suspect are going to be in practical use in the near future. For instance, look at this case here, presented almost 10 years ago, where that kind of a study would have predicted with total accuracy the future site of rupture on this patient who initially refused to have elective surgery. That's the kind of information that we really need to have. AI, of course, we have to say something about this because it's going to change everything in this area and everything else, but I suspect it's going to change it for the better as far as the topic that we are discussing. And it must be made clear that most of what I just presented and discussed relates largely to AAA in men. Women are very different as far as this pathology is concerned. It is a more dangerous disease that behaves very differently, and we really need to be more aggressive with their treatment. Lastly, let me show you this image. Just as a reminder that so much of decision-making depends on context and the individual considerations that we must all make in the treatment of our patients. Most of us, certainly myself, if presented with this, a 4.8 cm aneurysm, would say generally my initial reaction might be, well, we'd probably watch it for a while, perhaps. I'm sure somebody will want to be more aggressive. Some people may want to ask additional questions. Somebody else might think, well, I better fix it before the next guy does it because I'm sure the patient's going to go elsewhere if I say no. And that happens as well. That's part of the reality. Well, I fixed this. She is a woman, importantly. Her father had an aneurysm, and he died of a rupture, AAA. And she was scared to death, and she was adamant of getting this fixed. And she got it fixed with EVAR and continues to do well almost 10 years later. Thank God. Thanks very much.